Okay.
Anyhow, we're both on it.
Oh, look at us.
Perfect.
Okay, here, let me put this back. Okay. All right. So where we left off was, oh, go back. There we are. Okay, so as I said, reproductive years tends to be a little bit more even keel. Moving into postmenopausal, there is no such thing as normal bleeding in the postmenopausal setting. I get a chuckle over here. We'll get there. So at any point in time, if there is any bleeding in the postmenopausal setting, we usually have you contact your provider to discuss that further. But again, we'll get into more of that coming up. So just wanted to go over some common terms and common causes for abnormal uterine bleeding. Amenorrhea is the absence of any bleeding. Irregular bleeding is anything kind of outside what your normal would be. So if somebody comes to me and let's say they have typical 28-day cycles and then suddenly they're like, I haven't had a cycle for 42 days. And then it'll come back and I have it for 2 weeks. And then I have it 28 days later. So that's more of an irregular bleeding. Prolonged bleeding can also play into that. So anything over 8 days is considered prolonged bleeding. Heavy menstrual bleeding, this one's a little bit more challenging because a lot of people, when they see blood on whatever protection they're using, it's hard to sometimes gauge that. The standard, if you will, is anything above 80 milliliters, which again, unless you're using, say, a menstrual cup to measure, you're not going to really know if that's the case. So we'll have some examples to better outline that for you. And then intermenstrual bleeding is any bleeding that happens between your cycles. So if you're a 28-day cycler and suddenly every 14 days, like clockwork, you are having some bleeding, spotting, whatever that might look like, that's considered intermenstrual bleeding. Common causes, hormone or endocrine issues, structural causes. This can be fibroids, polyps, things along those lines. Infection is a big, big reason for this. So a lot of times if people come in and they're like, well, why are you testing me to see if I have an infection? I don't really have any symptoms. You might not have any other associated symptoms. It might just be abnormal bleeding. Bleeding disorders that might go undiagnosed. This is not that uncommon to go several years. And then suddenly, when we start digging in, we uncover you might have a bleeding disorder. And then medications can also be a big cause. Some acronyms that we oftentimes use in the gynecology world, PALM and Cohen. So PALM stands for polyps adenomyosis. This is when the lining of the uterus that is usually sloughed off each time you have a period grows into the uterine muscle itself. Leiomyoma or a uterine fibroid, this is typically a benign growth within the uterus, can be in the uterus, in the muscle of the uterus, or even on the outer portion of the uterus. And then malignancy or cancer hyperplasia is the thickening of that endometrial lining. For the Cohen component, we're looking at coagulopathies, ovulatory dysfunction, endometrial causes. So these kind of overlap if you think about it that way. Iatrogenic, this could be from medications or procedures that could lead to abnormal uterine bleeding. And then there is the lovely not yet classified.
And just a word on this. So this mnemonic came out like when I was in, well, I think it came out when I was in residency. And it's a way for us to kind of keep track of like what the causes are depending on the patient's presentation and age. And that's kind of where we're going to take you next. The PALM is more structural, the Cohen is more functional. So people who hang out with me, they know that I kind of divide like how the pelvic floor works by, is it a structural problem or is it a functional problem? And bleeding is actually very similar to that. We'll touch on some details as far as these big medical words are, so just hang tight.
Okay, so we're going to bring up a special guest next to give us an example of what abnormal or even normal adolescent bleeding can look like. So Preeti, you want to join us? Come on up. We're going to get cozy on the couch.
Yes.
It's like coffee talk, but you guys are probably too young for coffee.
So can I just like tell people who they are?
Yes, please.
I know we have. So Preeti is our rising senior and she's been hanging out with us this summer. And it's just been a wonderful addition, really vibrant with her dry sarcasm that she wants to share with us. But really brilliant. And we're just so excited that she joined us. So she's gonna read our first.
Okay. My periods have been super random and heavy since I started a year ago.
Sometimes I go a month without one, and other times it shows up in 2 weeks and lasts for 10 days. On heavy days, I bleed through 6 to 8 pads and pass quarter-sized blood clots. Ibuprofen helps with the cramps, but it's super stressful trying to manage this at school when it's so unpredictable.
All right. Okay. So,
Your thoughts?
yeah. What are your thoughts?
Sounds like kind of sucks.
It does kind of suck. You're
There's
right.
the diagnosis.
Uh-huh. Yep. Wholeheartedly.
Yeah.
Yeah.
How do you approach this patient?
Well, it kind of depends. So in this setting, if I will talk different treatment options, I'll talk further workup. I kind of give them the options because when they're young and I know, okay, she just started her period about a year ago, we know that things are really immature. Her hormones are still trying to figure out which direction to go, how to really work. So a lot of times we'll talk about ways to either help lifestyle management of what can we do to help you decrease that bleeding or cramping. Do we want to be looking at maybe putting you on a low dose birth control option that can help manage your periods? Or do we want to be doing more investigation? Are we concerned about perhaps a bleeding disorder that's gone undiagnosed or a structural concern that may be there that we just can't tell just from having a conversation? So a lot of times I kind of approach it as we can treat, we can explore, or we can do both. And I leave it up to patients within reason, of course.
Yeah. I mean, I don't really see these ladies.
I know, you always send my way.
I do. I'm like, oh, that sounds like a Jessica problem. I think just speaking off of like experience before I really dug deep into Urogyne, a lot of it is reassurance
Mhm.
because there's an immaturity that's happening in your hormonal axis for like the first 2 years when you first get your period. And the patients are upset. Parents are like, what do we do? Our kid doesn't want to go to school. She used to love school. She's real moody. Like we can't call it, and so it's a tough phase. It's a tough phase. And in our culture here in America, we're expected to just go back to, keep it moving. And so a lot of reassurance on that, and then looking out for like telltale signs that we'll go into, but we don't poo-poo everything. Sometimes it's like, well, yeah, well, my sister had irregular bleeding, but when I have irregular bleeding, I'm on the floor in a ball and I can't get up. Like that's a different presentation. And I think it deserves a little bit more, it deserves a different approach. And so those young ladies who are like, I know the period is, this is a problem. I can't do work. And that is very common amongst our teenagers. We want to be really sensitive to that and provide them with some relief. So, yeah.
So when we're talking about that, the bleeding concerns, again, the ovulatory dysfunction, especially in the first, this says 1 to 2 years, can be even upwards of 3 years. And I would even say a little bit longer, especially if the patient tends to be very active in sports. Oftentimes it is that counseling. 80 to 90% of cycles are in ovulatory, meaning they're not ovulating all the time because, again, their brain and ovarian connection is a little bit haywire at this point. We're still trying to lay the groundwork. So it is a little bit of a learning curve. So to Dr. Abanulo's point, it's determining, is this really disruptive to your life, or is this something where we just kind of have to get through this moment in time and let's see how the chips fall. The other component, again, I said, is that coagulopathy. So 13% of teens requiring hospitalization for heavy bleeding in particular do have von Willebrand's, which is a bleeding disorder, and it's likely undiagnosed until that moment in time.
Yeah.
I like it. And then, of course, going back to that, the iatrogenic causes. So medications, number one tends to be those hormones for sure. That's one of the kind of the downsides is if a patient says, yes, absolutely, I want to be on a birth control pill to help regulate my cycles. And sometimes it might make it worse. So that is something that I oftentimes will have to counsel my patients on, that we're going to try this, but unfortunately, it kind of is a trial and error. So until we give it a shot, we can't say for sure. Another thing that it could be, of course, infection, pregnancy, trauma, all of these things we need to be ruling out and making sure are not a factor here.
And just a word about ovulatory dysfunction. So that's one of those big medical words that we brought up before. The way to think about it is that you're not releasing an egg at a predictable time. And so we've got these hormones that go up, they rise, you release the egg, and as estrogen starts to peter out, your progesterone is going up, and it's this beautiful curve that looks like a two-seat roller coaster, right? But when you first get your period, it's like this. It's doing all types of stuff. You can't predict when you release that egg. And so there are other things in addition to just like an immature axis that can affect that as a teenager. One is PCOS, so polycystic ovarian syndrome, which has a new name that I have not memorized.
Polymetabolic ovarian syndrome.
Mhm.
Yep, that's going to take a long time.
I'm learning. I'm
Yeah,
working
no.
on me. Yeah, so that is something that honestly we kind of diagnose it in retrospect, and it's like, oh, so when you went a whole year without a period, that was more than just an immature axis. Another one is thyroid that we often miss in teenagers because we expect it to happen later in life. But they're often underdiagnosed for that as well. And then, yeah,
Mhm.
I just,
I would say those are the big ones for
Oh.
sure. So you want to seek immediate care if your vital signs suddenly change. What does that mean? Your heart rate is increased drastically. Your blood pressure might drop. So you're feeling faint, perhaps, feeling really dizzy or weak. If you have hospitalization for bleeding, especially if you need a transfusion, you need to be letting your provider know that, hey, by the way, last weekend I was in the hospital, had to have blood transfusion because my period was so heavy. That is times where we need to know, like now. Any family history of bleeding disorders. I've had this a handful of times. Patient comes in, she presents with kind of classical adolescent-like bleeding. We have this conversation and maybe we do a follow-up and all of a sudden it's like, oh, well, yeah, my mom has von Willebrand's. Okay, we should probably explore that and make sure that you don't have that. And then bleeding that lasts for more than 7 days. So I mentioned that 8 day is that prolonged period. So if anything is lasting more than 7 days, or you're soaking through a pad or a tampon in an hour, that is considered heavy bleeding. So again, I gave you the magical number, but that's hard to measure. So good rule of thumb is if you are soaking through a pad or soaking through a tampon, super heavy plus, that kind of thing, in an hour, you should get checked out immediately. All right, we're going to move on to the reproductive years. Preeti, thank you so much. Thank you, darling.
oh, sorry. All right, next up.
Who's our reproductive lady?
That's you.
That's you, the woman behind the screen.
All of it. Tell us who Fiona is.
Oh, if you have not met Fiona Extraordinaire, she wears a lot of hats in this clinic. She helps out at the front desk. She's been helping out in the back quite a bit, and she is my IT extraordinaire for this stuff.
Yes, yes, yes. And she's just so quirky and funny with her.
Yes, we absolutely love her.
We love the knowledge that she brings us from TikTok also.
Oh, yeah.
Important stuff.
Yeah,
Great.
absolutely. All right, go ahead.
Okay. Let's see. My periods used to be like clockwork, but for the past few months, I've been spotting between my cycles and bleeding much heavier than usual. During my period, I'm soaking through a super tampon every hour or two and passing noticeable clots. I'm constantly worried about bleeding through my clothes at work, and I'm just feeling exhausted all the time.
Okay, what are thoughts? Anybody?
Any thoughts?
Any thoughts? Any other questions that you might be like, Yeah.
Like that one kind of sucks too.
Yeah, it does kind of suck too. Yeah.
It's
Yeah.
a good thing we're magical beings because this whole period thing is really bring you down.
Yeah, it's true. It's true. Well, I would say for my reproductive patients, if you come in with a sudden change to your menstrual cycle, you better believe I'm going to work you up fully. And I am not one to leave a stone unturned. So you can be prepared for a blood draw, some imaging, at a bare minimum,
Yeah,
and then we go from there.
especially that spotting between cycles.
Yep.
Or even spotting after sex.
Oh, yeah.
That's another one. The one caveat, which I still think needs a workup, but it's more of just a reassurance, is like my periods changed after I had kids. I feel like the frequency changed a bit, the interval,
Yep.
right? And I think that's also a bit of an education piece. Like, no, nothing is wrong, or we've crossed all our T's, we've dotted all our I's. This is just the nature of your hormones kind of finding a new balance.
Yes.
seen that a lot.
Yep. I like to tell
It
my,
wasn't in my textbook though. I had to learn that first.
oh yeah, yeah, no, it's not. And I used to tell my postpartum patients that all the time. Your
Yeah.
body goes through a remodeling process
Mhm.
and your body is no longer what it once
Right.
was. You know, people used to say, oh, when do I get my pre-baby body back? It's not a thing. You get a body back, but it's not the same one. I can guarantee you.
You can work. It can be great.
Courtney's over here giggling, going, nope, no, it's not.
And you can make it a great body.
Yeah, you can make it a fantastic
It's a
body,
different body.
but it's a different body altogether.
Yeah.
Question.
I have an answer, maybe.
Those of us who have not yet reproducted.
Yes.
Reproduced.
Reproduce. I mean, we'll take it. Yeah.
Okay, you
Yeah.
were fine. Yeah.
Yeah.
For those of us experiencing like difficulty with their periods, could stress be a factor?
Yes,
If I
great
go to a
question.
new job, or
There's no
get-
stress here. What are you saying?
If it was a different job, I'm saying for a different job, not this job.
Anything you'd like to say about that job?
I started working out for the first time, and my body's not used to those things.
Yes,
Are there things that can affect my period in that way?
100%.
Absolutely.
Yeah,
Yeah, that
that's
is
a
a
great
great,
question,
great
actually.
question. Yes. So the easy answer is yes. Those things can absolutely impact your cycles. And one thing to keep in mind in terms of stress is the body takes a long time to process that stress. So it might not be an immediate change. It could be months from now,
Yeah.
where all of a sudden it hits and you're like,
It seems out of nowhere.
where did this come from? And then in talking, it might be, oh, I had this big life change that
Yes.
happened.
Yeah. I think we normalize stress a lot.
Yeah.
Especially in the US. We're actually workaholics.
Mhm.
We try to prioritize all of our different things in life. And so we don't realize how physiologically that stress can show up.
Mhm.
And I use this with pelvic floor issues, but the same is true with our cycle. You know, some people get a headache, some people get, pain in the back of the neck. And some people's periods get completely thrown out of whack and it can't explain it any other way other than that stressful
I
situation.
will say though, it's still worth a conversation.
Yeah.
Even if, let's say, I work you up for everything and we can't find anything, at least then we have an answer.
Mhm.
So I
Yeah.
think it's still important to have that conversation.
So.
Yeah. Okay, so common causes for abnormal uterine bleeding in women aged 20 to 44. Remember that asterisk, it's coming up, okay? Polyps, pretty darn
Talk about
common.
what polyps are.
So polyps
This
can
case.
be endocervical, which is a
Mhm.
polyp that's just kind of poking out of the cervix. This one usually bleeds after sex. That's a really common time frame to have that kind of abnormal bleeding. Or an endometrial polyp, again, benign growth, typically high up in the uterus in the endometrial lining itself. Yeah, those are,
Yeah.
yeah. Yeah, and then again, I mentioned the adenomyosis. This is when the lining starts to grow into the uterine muscle itself. This happens in about 20 to 35% of women in this age range. Fibroids, again, benign growths, kind of depends on where they're at within the uterus itself. Sometimes they're really disruptive to the actual endometrial lining. Sometimes they're not, but it doesn't mean they don't cause issues.
Really trying not to finish your sentences.
Okay, go on.
No.
I love this.
You're really amazing.
But you're also, I know, but you're also expert at this.
I'm also trying not to finish this.
Oh,
Wow.
I know you're trying hard. You're trying
Yeah.
hard. Well, okay, we'll go on to malignancy then.
Yeah.
That has I put this number up here because when we have a regular bleeding and we're not in that 40-year and
Mhm.
older, we really look for everything else. Cancer doesn't necessarily come to
Mhm.
mind clinically, but it's not 0%. So just like we've been stressing, if you can't find another reason why your periods are abnormal, please come see your provider, see us, and get that full workup so we don't miss that almost 2% chance that this could be a cancer that could have been easily cured. Abnormal bleeding is an early sign of uterine cancer. So if we get to it early, then we can really change the whole outcome. 35 and up, 6.2%. I don't call that nothing. And then go
I'd
on.
say that's a wild jump, by the way.
Yeah.
Like that's a
that switch.
significant
Yeah.
jump, right?
Totally.
1.6 to 6.2. That's not a
Mhm.
small jump.
Yeah. Just that 35 being a geriatric,
Yeah, we are.
reproductive age.
Darn it.
Coagulopathy, so bleeding disorders. that can be due to medication. So if you're on an anticoagulant, that can cause you to have abnormal bleeding. We do several of those workups. Liver disease is another one because your clotting factors are made by your liver. So if liver is not healthy, you're more likely to bleed. Ovulatory dysfunction, the vast majority of women that have PCOS will show up in this age group. Endometrial, which is a kind of weird one. It basically, for reasons that we cannot explain, the lining just continues to bleed despite your hormone levels being normal and we've tried all the birth control. The lining just will not hemostasis. And then iatrogenic, so things that we give you. I thought was really interesting with the antipsychotics and the SSRIs, which are mood stabilizers. Those can cause irregular bleeding. I don't think we fully understand that mechanism.
No, I don't think so either. I have not come across it in my years of doing it.
Pregnancy must always be excluded. Honestly, I'd probably do a pregnancy test on the teenagers too. Just I trust no one.
Absolutely not. No offense to the teenagers in the room,
but they would take my
but it
life
is
if
it
I
is
didn't
always
pass that.
yes, it is always. And I've had patients who are like, well, I haven't had sex in so long. It's like, well, unless you haven't had sex in a year, I'm still going to do a pregnancy test on you. Sorry.
Still doing it. Endometrial sampling. So things to look out for when you talk to your doctor and you're like, no, I'm having this irregular bleeding. And they say, oh, it's fine. Let's check back in 6 months. Just run out of there.
Yeah.
Just leave. Right. If we have reason for concern, which honestly in our practice can be kind of a low threshold, then we need to sample the lining and we need to do imaging of the uterus to make sure that lining is not thickened. This is especially true for women over 45 years, and in women who are minority, we actually drop that age to about 40 years old, where we have a lower threshold because the incidence is higher. If you're under 45 years and you have risk factors that could increase your risk of uterine cancer, then we're more likely to sample that lining. And those could be if your BMI is greater than 30, if you've never had kids, if you have unopposed estrogen exposure, which is PCOS always comes to mind because the way PCOS works is that polycystic ovarian syndrome is you've got this continuous estrogen exposure into the bloodstream. And so their periods are not true periods. Their periods are actually what we call breakthrough, which means that that lining has gotten so thick from that continuous estrogen exposure that it can no longer be supported. And so they slough off some of those cells and estrogen just keeps going. So those women are especially have a special place in our heart because we want to keep a close eye on them if things change. And then failed medical management.
All right, so seeking immediate care, active heavy bleeding with changes to those vital signs like we talked about with adolescence, increased heart rate, low blood pressure. Yeah,
Passing out.
Yep.
Be passing out.
Should not be passing out. Any risk factors for cancer, of course, if you have any risk factor.
At any age.
Yep.
30 years old, I'm sampling you.
Yep, absolutely. Any abnormal bleeding despite treatment for 3 months. Right? We've tried XYZ. It's still going on. We need to maybe pivot and look at a different direction. How can we help with this? We want to be, again, looking at that endometrial lining. If it's thickened, we're definitely going to be doing that sampling for sure.
Thanks, Fiona.
Thanks, Fiona. All right, here's our asterisk. This is why I said most of the time reproductive years, it stays steady. But to present our perimenopause, she's not there yet. We have fabulous PA students.
She's definitely
not there yet. But she's kind enough to read our perimenopausal example.
So I'm going to tell you about Mattia.
Yes.
Mattia is, I don't know, she's so smart and she's a quick study. She's good technically, and she is our almost graduating PA student that's been with us for 4 weeks, half of which I'm missing. And it just breaks my heart a little bit because it's so good working with you. I could talk about you all day. But so we've had the pleasure of working with her, and she's gonna tell us about perimenopausal.
Okay. My periods are becoming completely unpredictable. Lately, I've been skipping about 2 months and then having bleeding that might last for about 2 weeks straight with heavy flow and clots. I never know whether to expect nothing at all or a super heavy period, and the sudden changes make it really hard for me to plan my daily routine.
Okay. So here's my take on this, being our resident menopause, perimenopause expert. Mother Nature says, hey, when we start our period in the adolescent time frame, we're going to give you some hormones. And then perimenopause, we're going to do it again, but we're going to make it spicier. Right? Because it's like
It's too spicy.
it's too spicy sometimes. So similar to an adolescent, we tend to have more of this ovulatory dysfunction because it's also the time frame that I love to nickname as the yard sale phase of life, because we're born with a finite number of eggs. So the closer we get to menopause, the more Mother Nature's like, hey, we gotta get rid of these, gotta get rid of these. So things get a little crazy for sure.
Did you have
I feel like as medical professionals, we kind of anticipate the calendar of seeing periods get irregular and seeing flow become irregular. What does that look like in the perimenopause? Women aren't necessarily statistics, but when can they expect to maybe notice some changes with their cycles?
As early as 35, honestly. I have patients that come in and they're like, suddenly it seems like there was a switch that flipped. And 35 is typically the kind of the youngest that we'll see it. 40 is usually when things really start to kind of gear up. 45 is when, things get real spicy.
Yeah.
Mm-hmm.
And again, it's like there's different factors, right? We have moms that are having babies at older ages, so we have to put that in the mix. We also have different, careers and people who are like going back to being super active, and we have heavyweight champions in our office, in our practice, who picked it up at 40, 42, 43. So we just have to put all those pieces together and say, once we cross all our T's and dot all our I's, we know it's not cancer. This is a management going forward. So, yeah.
So, perimenopause, 45 to menopause. So again, those of you who attended my menopause talk know that that line that's drawn in the sand, I haven't had a period for 12 consecutive months. That is when you are considered menopausal. So 45 to menopause, this is when we do see fibroids tend to grow. They become a little bit more erratic due to that wild swing in those estrogen levels. So, we get these ups and downs. We used to think that menopause was this, or perimenopause was this lovely decline. Just giggling, yeah. Lovely decline, just so nice and slow. No, it is terrible. When I said it's spicy, I mean it's spicy. Of course, malignancy. We've talked a lot about this, but we still want to hit how important it is, because up to 24 per 100,000 women age 40 to 50 will develop malignancy. So that is, again, this is not a reason to, oh, I'm perimenopausal. This is common for me to just be bleeding because of that ovulatory dysfunction, because I'm in that yard sale phase. It doesn't mean that's always the case. So again, we're going to be looking at all of what we can. We're going to be doing blood work. We're going to be doing that ultrasound to make sure that that endometrial lining hasn't become too thickened. And depending on where you're at in your journey and how close you are to the finish line, that also depends on if we're going to be recommending to do a sample of the endometrial lining in the clinic or not. So that's,
Here's a gray area. 48-year-old comes in and she's like, I haven't bled for 4 months and I had a really heavy period. And lots of clots and everything. And then you do her ultrasound and her lining is 7 millimeters.
that is a gray zone. That is a big gray zone.
What would you do? So if she was fully in menopause, if it's 4 millimeters or more, that's abnormal.
Game off.
Period.
Yep.
But if she's under 45, that cutoff is 12 millimeters. So we have someone who's right in between who, what would you do?
I think it depends, because for me, I would, and again, every provider might take this a little bit different, but I would be looking at trying to determine how close we are to that finish line. And that can be done with a blood test called an anti-mullerian hormone. Tells me your ovarian reserve. If that's really diminished and we're looking at a 7 millimeter endometrial stripe, would probably be a good idea to go ahead and do sampling. But if it's like, hey, your ovarian reserve looks like you're sitting in your 30s, okay, let's give it some time. We've looked at everything. let's give it some time and see how this shakes out. So that's usually my approach. So seeking immediate care. If you have any abnormal bleeding that's associated with a pelvic mass, or all of a sudden you're like, I feel like I'm now 3 months pregnant when I wasn't before. Your uterus seems like all of a sudden I'm growing this belly I didn't have before, and I have all of this bleeding. Definitely get checked out. If that bleeding is associated with a sudden unexplained weight loss, we're not talking like 1 or 2 pounds here. We're talking like a significant amount of weight loss, or just general feelings of not feeling well, right? Like I'm exhausted all the time. Maybe your blood pressure and heart rate have been fine, but you're just not feeling right.
Fatigue.
Mm-hmm. Yep. And then any abnormal bleeding, if you're on a medication called tamoxifen, this is used in breast cancer patients. Very common for that endometrial lining to grow in that setting. And then Lynch syndrome is a genetic predisposition for cancers. So if you have a family history of Lynch syndrome, similar to any blood coagulopathy disorders in the family, it's important for us to know that.
Okay.
All right. Now we're bringing up our postmenopausal example.
But definitely not least.
Yeah.
Oh.
Oh, jeez. Okay, so if you guys know Regina, you know
Yeah.
this is like this is Regina. We love Regina. We love her dry sense of humor.
Yeah, that's the best.
It is seriously the
I feel
best.
like she and Preeti could probably go back and forth.
Yes. Yes, indeed.
Do we even need, does she?
She doesn't even need an introduction. It's Regina. Regina's our front desk extraordinaire who, yes.
And when she disappeared, the patients had me by the neck.
They really did.
You have
Where's
to bring her
Regina?
back, actually. I said, I'm working on it. So we're just happy that she's here.
Yeah.
Thank you.
Okay, go ahead.
Okay.
Go ahead.
I've been completely through menopause for 3 years, so I was really surprised when I started spotting out of nowhere a few days ago. It's just light bleeding, but with no pain. But since my period stopped long ago, I knew I needed to call.
I'm glad you knew that.
Mm-hmm.
Glad you knew that. We were just talking the other day about a couple of patients I've had who, well, one mentioned it just like as was like, oh, by the way, I had some spotting and been away. And then the other one uses a pessary, and so she had an episode of bleeding. And I went to do the exam, and I was like, well, your vaginal tissue looks fine. Let's just do an ultrasound just for, giggles. And both patients had endometrial cancer. And so it only takes one time. If you are postmenopausal, we beg you.
Yes.
Say something. Don't poo-poo that. We need to work it up. An ultrasound takes no time at all. So.
Mm-hmm.
Okay, so postmenopausal, driving this home, is 12 months of no bleeding. That is the definition of someone who's officially in menopause. Polyps, so that is where you have this increased growth on the inner lining of the uterus, but it's very focused on like one spot. So I always think of like the uvula in the back of your throat, but it's in the lining of the uterus. That's my imagery also.
That's my total
Right?
imagery.
That's probably exactly
just learned.
That's what it looks like.
Learn. Yep.
No, that's actually what it looks like on hysteroscopy. So almost 5% of these become malignant. So again, if it's mentioned, advocate for yourself to have it removed. I've seen patients whose provider said we can monitor it. I said we will not monitor it. We will take that out. So please say something, adenomyosis is an interesting one because our thought process is that uterus is becoming boggy and enlarged due to the inner lining kind of percolating into the muscle. But we assume, well, I'm in menopause. Why is that still happening? I have a couple of soapbox theories about that, but overall, without taking you down my personal rabbit hole, we do continue to make estrogen when we're officially in menopause. Those ovaries are still working. They're still protecting us from bone and heart disease. And we don't really see a full drop off until 65. So you have on average about 14 years where that estrogen can still impact the uterus and its lining. So that is why adenomyosis can still be found in someone who is in menopause.
I would take that a step further and say if your BMI is over 30,
Mhm.
we also know that fat tissue in particular creates its own form of estrogen. So you're more susceptible to those things happening. And one more little caveat, please.
Mhm. Of course.
Polyps. Endometrial polyps, I would, or not endocervical polyps, I would put in the same
Yes.
kind of statement as don't just leave it alone. Like
Yes.
you should probably have that biopsied
Mhm.
because in cases that can be malignant.
Absolutely. Yeah, right up there with the endocervical ones. So malignancy, this is one here, when we talk about malignancy, we're talking about in the full lining, not just in that polyp that was missed. And 90% of those cases will present with what's called postmenopausal bleeding, or PMB, like you see on the slide. And then endometrial, so the most common cause is the atrophy itself, is the thinning of that lining itself. So I love when those come back and it's like, oh, the lining is only a millimeter thick. I'm like, okay, we can proceed. And that is the usual result of the ultrasounds. All right. And I don't think we can say this enough. Even if it's just one time,
Mhm,
please come and see us.
mhm.
Most uterine cancers, the earliest sign is bleeding. And so we are lucky to have that. So please come on in. And oh yeah, so thank you.
Thanks, Regina.
Anyone have questions about that before I dive into my little side spiels here? No? You good? You good? So for non-vaginal bleeding, so in our line of work, a lot of women will, not a lot, sometimes women will come in and they'll think it's vaginal bleeding, and then we do the workup, we place a speculum, and there's nothing there. And so other causes that might cause bleeding into your underwear or your lining, one is urinary. And so this is blood in the urine, and it can be visible, which is usually what brings you in on your own, but it can also be microscopic, which is where it keeps showing up in your urine samples. And you're concerned that it could be something more than just atrophic bleeding. Possible causes definitely could be an infection. We want to look for our typical traditional bladder infections that kind of affect the dome and the bigger part of the bladder. But if you're also having urethral burning, urethral pain, we also want to look for ureaplasma, which can cause the urethra to bleed very easily and make it real friable. Kidney stones, we say kidney stones, but they can be in the bladder, they can hang out close to the urethra. Inflammation, which you guys know has a special place in my heart. So interstitial cystitis, which is a chronic inflammatory process that's happening in the bladder that can cause it to bleed very easily. And then other underlying causes. Call your provider. And then rectal bleeding. The rectal bleeding is something that can show up in your 20s, your 30s, your 40s. And you think it's part of your period or you think it's intermenstrual bleeding, but it could be colon cancer. So don't stop, go. Always talk about it, always bring it up. Sometimes we assume, oh, it's a hemorrhoid or it's this, it's that, but just always confirm. So that is blood originating from the lower GI tract. It'll pass through the stool or noticed with wiping. It can be hemorrhoids. Anal fissures is one that I treat fairly often because of the type of practice that I have. But in my women that have really tight pelvic floors and they have trouble evacuating, that sphincter just doesn't relax when you want it to relax. And so you might have pain with bowel movements, and then you might have bleeding with bowel movements. And that's because that skin is actually tearing from the kind of paradoxical stretch that's going on with it not relaxing. Polyps. And then, like I said, there's cancer and an inflammatory bowel disease. Call your provider. Call your provider. If they don't call you back, you have to call them again. Okay.
Question. Fiona, do we have any questions in the chat? Okay, excellent. On this last slide, I did include our YouTube channel. So if you want to go back and rewatch tonight's talk, you certainly can. You can also watch all of our other talks from earlier this year.